Assalamualaikum and good morning. Um, how are you, all of you? Thank you very much, Dr. Imi Sairi and the Committee of Breast and Endocrine Fellowship Seminar for this opportunity. Today, I'm going to talk about chronic granulomatous mastitis. It's very unnerving to be the first speaker of the day when everything is new, because this is the first time I use AMIT. However, we will try, and if there's anything, you all can ask for any clarification. Okay. Chronic granulomatous mastitis and evolution and management. That's the title topic given to me. I will try to elaborate as much as I can, but of course, if there's any shortcoming, it will be shared among us, and all can contribute as well. Okay. CGM, or also called as IgM, idiopathic granulomatous mastitis, granulomatous lobular mastitis, or granulomatous lobulitis, is a rare benign inflammatory breast disorder of unknown etiology. It was first described in 1972 by Kessler and Wallach, and the importance of recognizing the disease is because of its presentation can clinically and radiologically mimic breast cancer, leading to diagnostic challenge as well as anxiety during the evaluation. This is probably small seen on your device. These are the collective presentation or case reports or case series or studies in around the world as of Litoprak F et al. A few years ago in presenting this disease around the world. So for the pathogenesis, CGM is exactly unknown, the pathogenesis, but different step occurs at disease progression. One of the steps is non-specific lobulitis, which involve multiple lobules and causes reactive lymphocytic infiltration. The granulomatous formation with central suppurative necrosis occasionally occurs because of lobule deformation, and abscess develop because of the increased number of these foci. So this process starting with non-purpural secretion has been proposed as the most rational theory for the pathogenesis of IgM, as well as hormone imbalance due to deviation of estrogen-progesterone ratio or hyperprolactinemia is believed to cause this secretion and inflammation. This will bring on to ductal ectasia, intraductal accumulation of the protein-rich secretion. This causes permanent inflammation occurs following the perforation of the duct and contact between the secretion and the stromal cell. This accumulation of secretion, ductal ectasia, galactoporritis, and chronic GM are steps in the pathophysiological process. And this can be due to autoimmunity against secretion that is extravasated from the lobules that actually considered to cause this event. So, as everybody knows already, the main etiology is remain unknowns, but there are postulations. The postulation that has been listed like alpha-1 antitrypsin deficiency, oral contraceptives, gestation, birth and breastfeeding, hyperprolactinemia, smoking, autoimmunity, microbiological agents, as well as ethnicity. Okay. What about alpha-1 antitrypsin deficiency? We know that this alpha-1 antitrypsin is a glycoprotein synthesized by the hepatic cells. The function is prevent the destructive effects of proteases secreted from activated neutrophils. It's also accepted as an acute phase protein, and deficiency leads to primarily lung and liver pathologies. However, there's one case presentation in 2001 by Shalfout et al. Demonstrated alpha antitrypsin deficiency in a patient diagnosed with IgM. And they did not find any other etiological factors. So it suggests that the alpha-1 antitrypsin deficiency is the cause. However, this protein has not been further studied. What about oral contraceptives? The secretion theory has an important place in the pathophysiological of IgM. Oral contraceptives have been considered a potential etiological factor as they increase breast secretion. However, any significant association had not been determined. In Yilmaz et al., it had not been found any significant association between oral contraceptives and IgM. In the literature, the association also noted that between IgM and oral contraceptive has been reported as to range between 0 to 42%. Okay, what about gestation and breastfeeding? Because most of the patients are within reproductive years, so it has been suggested that these factors has an effect. Parity also has been considered in the etiology, in which hormonal changes after birth led to increased breast secretion and subsequent inflammation. After giving birth, breast lobules switch to secretory phenotype and ductules and found to be dilated. This hypothesized to be an initiating factor for IgM. Almost all studies to date have reported parity to be associated with IgM. The number of births increased. The incidence of IgM also increased as reported in previous study. And Yilmaz et al. Noted that breastfeeding for longer than 18 months was implicated as a risk factor for IgM recurrence. Okay, hyperprolactinemia. We know that hyperprolactinemia causes lactation, or prolactin causes lactation. So it has been considered responsible for the pathogenesis of IgM. This is also supported by one case presentation by Rowe, determined to have a patient comorbidity with prolactinoma in one IgM case. However, no further study had not provided the details of prolactin level. In Bani, Hani et al. Analyzed prolactin level in 7 of 24 cases and only found elevated prolactin levels in one patient. And Erhan et al. Carried out a case series studies on 18 women and reported recurrences in 3 cases and identified 2 with hyperprolactinemia. Maybe there's some association but not conclusive. Okay, sorry. What about smoking? Smoking has been blamed for a lot of things. One of it is IgM. While smoking is among the factors considered in the disease etiology, definite association has not been established because the studies are having mixed results. A study by Asaglu et al. Noted 14 out of 18 had a history of smoking, where it's about 77.8%, whereas Balsian et al. Reported that none of their 20 cases had a history of smoking, so maybe it's not affected. The smoking rate was about 34.8% according to Ozan, and 16.7% according to Al-Kafaf, and 50% according to Ozel et al. So it's still inconclusive. Maybe it's all multifactorial. And what about autoimmunity? Because the response of IgM to steroids, a hypothesis that suggests an immunological basis for IgM has received considerable attention. Good response to steroid and immunosuppressive treatment and patients who had recurrence to steroid, has a good response to steroid, patient with extramammary involvement, which are autoimmune in nature, has pointed out to have this what do you call that, possibility of autoimmune hypothesis. However, all studies also had not supported the autoimmunity hypothesis. And last, sorry, this is the microbiological agent, Corynebacteria species has been implicated in the causal factor of IgM. And they are, it's a gram-positive aerobic bacilli, and there are 4 different species that have been detected. The most is Corynebacterium cropesti, and the rest is Amicolatum and Tuberculostereotychum. However, that's why it's when there are microbiological agent, it's not called IgM already, right? But it's probably at the start of the event. So what about ethnicity? Does it count? These are the series that has been analyzed by one of the papers. It's noted that there are a lot of cases noted in Turkey, China, South Korea, as well as United States. And in between the numbers of cases, Saudi Arabia, that includes Malaysia here. This is, I think, studied by Ms. Azlina a few years ago. And the rest are very little cases are being reported. And the highest cases reported is in France. And it seems to be related to ethnicity, where highest is from Asia and Mediterranean region. And in Barreto et al. In the US, the majority of cases are noted to be in the Hispanic descent. Okay, what about the diagnosis? Clinical findings, diagnostic imaging, and biopsy of IgM or CGM. Of course, when the patient is presented to the hospital, we will proceed with our usual triple assessment. And the clinical findings of the condition is wide. But however, the most common presentation is unilateral mass that occur in any quadrant of the breast, but noted that the upper outer quadrant can be the most involved site. The mass may be painful and can be associated with erythema that make us think that this is more of an abscess. However, podorange appearance and nipple retraction may also be seen that makes it very similar appearance in malignancy, as well as abscesses and draining tracts or fistulae can be also a presentation. The extramammary presentation include axillary lymph nodes, erythema nodosum, as well as arthritis. The nipple retraction already noted up here. And patients are in the reproductive years, even though some patients as old as 80 years old has been noted to be presenting with this condition. What about diagnostic imaging? We have the usual mammogram, ultrasound, as well as MRI being used for the diagnosis of this condition. In mammogram, there are no specific, one second. There are no specific radiological findings that could point towards the diagnosis of IgM. The workup can be done in the same way as breast mass. would be reevaluated, like mammogram for a woman above 30 years old and ultrasound in a woman below 30 years old. There are no pathognomonic mammographic findings that would point towards a diagnosis. The most common mammogram findings include focal areas of asymmetry, can be single or multiple, can be skin thickening, lymph nodes, or frank mass. Like this image on the right hand side, my right side, noted a mass on the patient's upper inner left quadrant interpreted as suspicious for malignancy. Yeah. Can we see the difference? This will make us think of malignancy. Uh, And on ultrasound, the most common sonographic finding is that of heterogeneous echogenicity, irregular shaped mass with no distinct margin. The tubular configuration is seen in a majority of cases. The ultrasound is a bit more like CA or abscess findings. This is hypoechoic lesion, irregular margin, looks very much like very scary looking mass if we see this. And the target breast ultrasound showed irregular hypoechoic mass. This is from Barreto with angular margins and a small internal anechoic area at retroareolar region. Ultrasound findings are highly suggestive of dire invasion of the nipple areolar complex. Okay, if we go forward for MRI, MRI lacks the ability to distinguish between tumor and inflammatory process. The most encountered enhancement pattern at MRI was a segmental or regional area of non-mass enhancement within which ring enhancing lesion were identified like this. And these are the explanation of this MRI. And you can see after contrast enhancement of the regional non-mass enhanced heterogeneous with annular enhancing lesion ranging from a few millimeters to centimeters. Okay, that's the imaging. So we go as usual, the triple assessment. After imaging, we'll do biopsy. So in HPE, histopathology revealed features of granulomatous process with multinucleated giant cells, epithelioid cells, and macrophages forming non-caseating granulomatous around lobules. Neither evidence of malignancy nor any specific organism was found. This is the important thing that must be excluded because IgM is the diagnosis of exclusion. Absence of caseous necrosis was marked in the granuloma, which was surrounded by microabscesses. Interstitial inflammation was observed in all cases, but perilobular, luminal, and intraepithelial inflammation were less frequent. In Yilmaz et al. Noted that abscess formation was observed about 45.4%, almost half of the cases. These are how it looks like in pathological microscopic appearance of the lesion of this IgM, where it can be seen that replacement of breast tissue by a diffuse inflammatory infiltrate of histiocyte and lymphocyte with some epithelioid multinucleated giant cell. This is the giant cell. And perilobular chronic inflammation, where no organism can be seen, no features of malignancy. Okay, usually it's diagnosed with true-cut biopsy because it's seen, but in some places they can, with good pathologists as well as cytologists, it can be seen on FNA as well. But true-cut biopsy is the best diagnostic method for this chronic granulomatous mastitis. Okay, management. This is the most difficult part because it's a diagnosis of exclusion. You don't want to miss a lot of things before you start diagnosis. You start this treatment for the patient. Okay, treatment option which have been tried include observation, steroid, antibiotics, immunosuppressive agents like methotrexate, and lastly would be surgery. Okay, surveillance can be done. Sometimes used as initial approach in patient who present with the initial episode of IgM. Observation with based on studies that reported successful management with conservative management. There are studies that is noted that it actually go away by itself. However, this had been seen by Lai et al. In their study reported spontaneous resolution in 50% of cases and stable disease in the other half, means almost 100% has been observed. However, in this observational method, resolution can sometimes be prolonged. Sometimes you want to settle the problem as soon as you can for the patient. As seen in the study by Lai et al. And the colleagues, approximately about 2 years, where they observe and wait for the lesion to settle by itself. The second one is systemic antibiotic. It has also been used as treatment, although controversial because supposedly no microbiologic organism has been reported to be as the etiological factor, but it can be used during active infection and can be guided by microbiological data that's available at the time. It can be super infection, and chosen agent usually directed against gram-positive organism. What about steroids? Systemic steroids has been the mainstay of treatment for IgM. A lot of studies has proven this and noted that complete resolution of diseases in about 79% in Pendy et al. And the time to resolution was about 5 months. And the total 23% recurrence of the disease resolved with the second course of steroid. So steroid can be given at multiple courses. In retrospective study done by Oran et al., 25 out of 46 patients were treated with steroids. Of these, only 3 failed to respond and required surgical excision. And other studies demonstrated similar benefit with steroid therapy. The most recommended duration is about 3 to 6 months, and doses as high as 60 milligram prednisolone can be used with a gradual taper. However, long-term steroid therapy may have several side effects such as hypertension, weight gain. Perempuan kan tak suka lah weight gain ni. Glucose intolerance, Cushing syndrome, as well as steroid myopathy. In immunosuppressive agents such as methotrexate, azathioprine can also be used in cases that are resistant. However, there are limited data regarding methotrexate use in IgM, and so far I have never embarked on methotrexate in our patients. Okay, there's a studies comparison. This is a randomized trial. Compared the outcome of low dose and high dose corticosteroid in the treatment of idiopathic granulomatous mastitis by this group of researcher from Iran, where the low dose is about 5 milligram daily for 2 months and the high dose is 50 milligram for 3 days, 25 for 3 days, so 12.5 for 3 days, and 5 milligram thereafter in total of 2 months. It notes that in conclusion, high dose prednisolone has high success rate with lower recurrence in the treatment of IgM and could reduce the need of surgery. However, further studies are necessary because they have only about 30 patients, 15 each arm. Okay, what about excision? Last but not least is excision, because sometimes the lesion is traumatizing to the patient, because they usually equate lesion in the breast to something very dangerous. So surgical excision was actually wide excision. It was the mainstay of treatment before 1980 and is still performed depending on local expertise and preferences. Multiple surgeries, however, may be required to achieve final remission. 8 of 11 patients in Yao et al.'s and series underwent more than one surgery, including 8 women initially treated with incision and drainage. We also have a few patients who had initial ND on active infection and had steroid, but after which, at the end of the steroid, recur and need to be prolonged, the steroid courses. The number of surgical intervention per patient range from 1 to 6 with a mean of 2.8. In some cases, mastectomy is performed with breast reconstruction, and there are also some with not total mastectomy, maybe a wide local excision. It's a big part of the breast has been removed and partially reconstructed with autologous tissue. And delaying surgery after control of the acute inflammatory symptom limit the occurrence of surgical scar and sinus tracts during the recovery period. And continued treatment with steroids after surgery is also associated with improved outcome. And the authors emphasize the importance of a wide local excision with negative margin to decrease the risk of recurrence. Okay, long-term follow-up. Yes. Because recurrence is well-known complication with reported range of 5 to 67%. It's very wide range, varying depending on the length of follow-up and initial treatment approach. In a review of 144 cases, treated surgically, yielded recurrence of about 23.6% compared to about 25.8% recurrence in women treated with steroids. And there are overall recurrences noted here in a few studies where Wisa et al. Noted 17%, Ms. Azlina noted about 50% after the high dose prednisolone, and Akbulut et al. In their retrospective studies of a lot of cases reported high recurrence rate in patients receiving corticosteroid. And clinically, this recurrence may present months after treatment with fistula formation and secondary infection with abscess formation. These make long-term follow-up necessary for the patient, where we need annual mammogram and ultrasound, usually 6 monthly after the acute episode, until the disease has resolved. And the long-term treatment with steroid also has been used in disease control. However, the side effect limit the use of the treatment option. If reconstruction surgery is planned, I mean, if patient has been excised and we plan for reconstruction, recommended to delay the procedure until at least 6 months after the acute episode to ensure the disease tissue had been excised prior to the definitive treatment. On going to the reconstructive surgery, it has been removed before, removed all. So at the edges too, it's not recurring anymore. Okay, this is the suggestion of algorithm of treatment by Thomas et al. It's a bit small, but this is what has been explained just now, where I pun tak nampak. Aduh. Okay, okay lah, macam tadi, we take history, examination, ultrasound, mammogram. This is the triple assessment part. After that, disease is mild, observation. Patient is asymptomatic. Sign of infection, antibiotic. Resolution, yes. If no, alternative therapy, such as steroid. No signs of infection, steroid. severe symptom with signs of infection, systemic steroid and antibiotics. And ultimately, if this all progression or stable or remaining, may need to proceed with excision. Okay, I have two case presentation just for a while. One of which I have two presentation. Just a little bit. Case one, this is lady lactating, 27 years old, presented with clinical breast abscess in 2017, treated with systemic antibiotic, repeated ultrasound and biopsy. Note that it's a CGM. She had one course of steroid. 2018 it resolved. Ultrasound, no trace of the CGM. And while pregnant 6 months, another year, had another clinical breast abscess after a few courses of antibiotic. The abscess resolved, but in early ultrasound in 2019, we repeat the ultrasound and noted a small lesion, which is biopsy. It was proven that it's also CGM. This time, the patient was put on conservative management. The lesion resolved, but noted intrarectal lesion very small, and scheduled for biopsy. However, it disappeared by the time the biopsy date has come. This is the initial ultrasound. Large lobated heterogeneous lesion, moving debris, macam betul-betul lah abscess. This after the antibiotic, when we biopsy, noted to be CGM. And this is when it is small, when we repeat ultrasound guided biopsy, and it's also noted to be CGM. Okay, this is another case. A 44-year-old lady, nulliparous, no non-medical illness, presented with the right breast lump since about 1 month. No fever or skin changes, not CP or HRT, no family history of breast malignancy. Clinically, mass non-tender. Clinically, it looks like CA. However, true-cut biopsy was done in the clinic because it's large, freehand true-cut biopsy, after which she is scheduled for ultrasound mammogram. The right breast lesion, even though at the time it was, the HPE was still pending, BRATS 5. And the HPE was CGM. We are all rejoicing at the time. We thought, yay, it's good for her because it's CGM. So she completed prednisolone for about 6 weeks. And she claimed that it's smaller. However, on reassessment, noted that the lesion was bigger on ultrasound. So we re-biopsy underguided, even though it's bigger now. Okay, I'm sure you all know where I must be going by now. So this initial ultrasound, which is irregular. And this is the second ultrasound, and biopsy was guided. So the second biopsy showed that it's IDC, very sad for the patient this time. And at the time it was quite big, and she was diagnosed as locally advanced, started on neoadjuvant chemotherapy. She completed the neoadjuvant, underwent mastectomy as surgery, and final HP showed that it was invasive breast cancer post chemo. It was noted also that the IgM also coexisting with the carcinoma. Now she's at 2 years post treatment and currently no local or distant recurrent noted. Alhamdulillah. So conclusion, IgM can mimic breast abscess or inflammatory breast cancer and may coexist. Typically affect young women of childbearing age with history of pregnancy lactation in the previous 5 years of the current presentation, and presenting with a palpable mass. Occasionally, we associated erythema and palpable nodes, and a diagnosis of exclusion based on the presence of non-casseting granuloma at pathology, and often associated with microabscesses with no evidence of microorganism. Because when we want to start steroid patient, we, God forbid, the patient has STB at the same time, right? So make sure there's no organism there. No radiologic or pathognomonic findings specific to this entity. However, a focal asymmetry density at mammogram and ultrasound with hypoechoic breast lesions with striated echo texture and tubular extension, and MR finding may be ring enhancing lesion, but we seldom get to MRI because the MRI is expensive and had a long time to wait for the appointment. By the time patient dapat appointment, MRI maybe dah resolved by itself. The treatment is initially antibiotic if there's active infection or active, secretion, fluid coming out from the lesion, and or oral steroid and surgery to perform for disease control later on if does not resolve this to medical treatment. And it can also be observed even though it takes a long time. Both surgical and conservative management approaches are associated with similar recurrence rate on the order of 25%. So we have to observe the patient for a long time. And the disease has a tendency to resolve itself gradually with expected management, but may take a prolonged course. Okay, I think that these are my references. And thank you so much for the applause. Thank you for the advice and the best time to form by Steve. Okay, thank you, Adi, for your question. Usually, for us, we will give the patient a course of antibiotic first. If it's diagnosed on ultrasound as query, usually it will be reported as partially liquefied breast abscess. So with that, we will give patient antibiotic, and most of the time after 1 or 2 courses of antibiotic, we will reassess ultrasound and at the time we biopsy. And if the patient needs a drainage, if the drainage is open drain, we will biopsy the wall of the abscess, as well as if the patient is drained percutaneous by ultrasound, also we ask them to biopsy the wall. Help us to biopsy the wall. Okay. Oh no, we don't have. We usually diagnose as macam exclusion lah. Macam we do ESR, meant to, if ESR is suggestive, then only we send all these things. Sometimes tak sampai PCR pun, because the TB breast satu after the biopsy probably they can see, and two because that we don't really have that testing here. I have one patient with that, with TB breast, where patient had a drainage. After which she went for dressing elsewhere, and it recurs because the first drainage was done in bedside, so wall abscess has not been taken biopsy. So second, when it recurs, second drainage, we do under GA and we take the wall abscess and noted to be TB positive. After which we started the patient on that anti-TB for 6 months, and she, alhamdulillah, resolved. Does that answer the question, Ms. Hidayah? Q&A. Question: define steroid resistance. Steroid resistance. Yeah. Oh, I've never used methotrexate. Usually we give a longer steroid course, because if we look at the literature tadi, dia kata 3 to 6 months. Usually kita punya steroid habis about 6 to 2 months. That's why after which we will continue a bit more of the 5 milligram for another 2 weeks to complete the 2 months steroids, and after that we'll see. But so far tak pernah progress to methotrexate lah. Limitation for repeat antibiotic. That's why I think kita limitation until the patient symptomatic wise. Usually saya do a course lah. After that, if it's still there, we advise the patient for excision. Usually by the time that dia cuma tak resolve completely, tinggal sikit lagi, and we operate on a smaller, getting smaller. There was contraindication for breast cause weight for lower deviation. Oh no, the presentation to the patient second patient was actually big tumor to start with, so I don't feel safe to conserve the breast afterwards. It's about 7 centimeter big on diagnosis when she was diagnosed of having breast cancer. Limitations they don't use hydrocod. I've never used IV hydrocod. Tapi ada juga nampak dalam tu diorang guna metalpred also, but I've never used. But maybe the other resident in the audience here have used IV hydrocod. Mr. June?
Okay, I'm sorry, Ms. Maya, we have to limit
Okay,
the
okay.
question because we have
I'm
limited
okay.
time. Thank you very much for very good talk. Now we're going to move our backstage for a while to invite the second speaker. Thank you very
Okay,
much,
thank
Ms.
you so
Maya.
much.
Okay, we have poll here. I'm really sorry. I hope that participant can answer the polls. Ms. Maya will give the answer at the end of the.
Except dalam bahasa Inggeris apa? Except dalam bahasa Melayu apa?
Okay, it's not more of question and answer. I think it's to see how our practice now. Nowadays, you probably can do either or, and with the evidence, you can see that it's probably better in hydrosteroids. Okay.
Macam mana nak ejek outside?
Thank you so much.
Thank you again, Ms. Maya. See you on next session.